This program is brought to you by Emory University.
All right, well, let's go ahead and get going. Think I know where we left off, but remind me when we get to it. But I wanted just to go back and look at two things I think that we talked about before. Since we met last, the European guidelines for acute coronary syndromes came out. And so I just wanted to go through those updates. Last time we talked, and we kind of emphasized that one of the changes we had sort of recommended was not to give clopidogrel or Plavix upstream in non-ACS. So somebody comes in with a non-STEMI, don't load with Plavix. And we talked about that. We had taken it out of our algorithms, and that was sort of based on the Acute trial, which used prasugrel upstream. And they found that there was no benefit, but there was a lot more bleeding, especially in patients who ended up needing to go for surgery. There was another trial that then came out, another randomized trial of preloading in non-STACS, and the bottom line is there was no benefit. And it did. And one of the questions always came, do you wait? And one of the issues with the trial here that we talked about was there was no benefit, but patients often went to the cath lab pretty quickly. And most patients with non-STACS end up going to the cath lab, the following morning. And so we cath these people pretty early. One of the questions always comes up is, well, what about on Friday night? You admit the guy on Friday night, they're going to be in the hospital all weekend. Don't you need some antiplatelet protection to get them through the weekend? And in this randomized trial where they found no benefit to preloading, they also broke down whether you sat on the patient for 24 hours. And again, even if you sat on them for 24, 48, 72 hours, you weren't finding a benefit to upstream Plavix. And so it's interesting that ESC guidelines actually made preloading a class 3. So I thought that was really important to go over. So not only is it probably not beneficial, they're recommending it against it, a very strong recommendation. And I would probably agree with them now. This is a class 3, do not do. So do not give 600 of Plavix upstream anymore until you've defined the anatomy. It's good to give it in the cath lab, and this doesn't include STEMI, but this is really for non-STACS. So that was one thing I just wanted to kind of go over. I think we talked about that. The other thing, we went through prasugrel versus ticagrelor last time, if I recall. Please step in if I didn't, because I'm giving this lecture to you guys and the interventional fellows, and I've given it so many times that I kind of forget where we're. Well, I think this is where we kind of left off last time, as we said, which is better, prasugrel or ticagrelor? And we made the argument prasugrel was better based on some of the more recent data. And actually, I was glad to see the European guidelines put in their non-STACS guidelines that prasugrel should be considered in preference to ticagrelor for patients who get PCI for ACS. So 2A indication again. So not only is it the digestive, but we're now seeing guideline recommendations moving away from ticagrelor. So if you're writing for ticagrelor, if your attendings are writing for ticagrelor, you should really refer them to these European guidelines to say, stop it. It's expensive, it's twice a day, causes dyspnea, and it's not the recommended anymore. And I think we went through platelet function testing and genetic testing last time, if I recall. And I think we kind of ended here with prasugrel is preferred over ticagrelor in ACS. Clopidogrel, guided by either genetic or platelet function testing, will give you similar outcomes. And we really should reserve ticagrelor for those who can't get clopidogrel and can't get prasugrel. Does that sound right? Does that sound where we ended last time?
Yeah, it sounds like just where we ended.
Okay.
I'm wondering if we didn't cover the clopidogrel genetic testing platelet function assay stuff.
Okay. All right. Well, let's go through that real quick. Okay. So maybe we stopped here with the PRAS story. So the question is should we be thinking about clopidogrel and ACS? And the answer is probably yes. Now, I want you to start with the guidelines. Guidelines recommend recommend against clopidogrel. So if you're writing for clopidogrel and you've written ACS in the chart, you should automatically feel bad about yourself. So you feel bad that you're doing the wrong thing if clopidogrel is being written and ACS is a diagnosis. This is STEMI or non-ST-ACS, okay? So start feeling bad about Plavix and ACS together, okay? And I'll tell you, 70% of the time when we do ACS treatment in the Emory system, we give Plavix. So that's what I'm trying to say. You guys should start feeling bad about yourselves a lot of the time. Okay, so Plavix is a prodrug. 85% of the time it goes to an inactive metabolite, but there is an active metabolite that's actually the minority of the clopidogrel drug, and it takes a while compared to some of these other drugs to be activated. However, and one of the big reasons that people don't do well with clopidogrel is that about a third of, quarter to a third of patients aren't able to metabolize clopidogrel. They have an abnormality, a genetic abnormality, that in the liver, they have the CEP2C19 reduced function allele that makes their liver not able to metabolize the clopidogrel very quickly. And this occurs in, a quarter to a third of all patients. Now, the flip side is, I want you to flip that and say the vast majority of patients actually can metabolize clopidogrel quite well. When you go and look at how clopidogrel compared to prasugrel and ticagrelor, there was two major studies. Clopidogrel was compared to prasugrel in the Trident-TIMI 38 study, large study, moderate to high risk ACS, undergoing PCI. This was only a PCI population, and they actually were randomized at angiography, not upstream. So you had to wait to see what the anatomy looked like before you gave them the drug. And what you found is that prasugrel was better for about a year compared to clopidogrel. I want you to pay attention to this. 2% absolute risk reduction, but there was a 0.6% increased risk in major bleeding complications. So 2% absolute, 0.6% increase. Now, what was interesting is when you go back to the benefit of prasugrel over ticagrelor and looked at it compared to whether they were a genetic responder. If you were a genetic responder, if you can break down clopidogrel, if your body can metabolize clopidogrel to its active metabolite in an efficient way, look at how clopidogrel responds to prasugrel. The odds ratio is identical. This same drug, this same efficacy. So don't think that clopidogrel is at all inferior to prasugrel. It is the same efficacy under one condition, and that one condition is that you know that it works. So if clopidogrel works, it works just as good as prasugrel. It is the same bleeding, same outcome. But if clopidogrel does not work based on CEP2C19 allele function, not only is prasugrel better, but now your number needed to treat is not 50, it's 16. So the benefit of prasugrel is not more potent than clopidogrel necessarily. It is just that clopidogrel doesn't work in a third of our population very well. So that's what I want you to change your brain on. It's not that Plavix is a bad drug. It's that in a third of the patients, it doesn't work that well. And if you don't test it, you don't know if the person in front of you is in the third it doesn't work well, or if it's in the 2/3 that it works well, okay? So that's the thing. If you haven't tested clopidogrel, you don't know what you're doing. That's the bottom line. Again, if you go back to the Plato trial and you look at ticagrelor and how it stacked up against Plavix, and you looked at the genetic responders, again, the benefit was in the non-responder group, and there was no statistical benefit in the responders. This is an interesting trial. We never hear, I bet this is a Euclid trial. I bet nobody's heard this. And that's because you don't hear of important negative trials, okay? So I bet nobody's heard of this study. But it was a really important study because it was negative. And it's really great. I give the AstraZeneca credit for doing this trial. They thought ticagrelor was a good drug. and they thought it was better than Plavix, and they put their money where their mouth was, and they said, I want to test ticagrelor not against clopidogrel, but against clopidogrel in patients that clopidogrel works. So they did genetic testing ahead of time. They excluded all the non-responders, and then they went head-to-head with clopidogrel when clopidogrel works. And they did it in almost 14,000 patients. Now, this was a PAD population, but PAD population has a lot of cardiovascular events, and that's what actually their primary endpoint. And look at this, in a huge trial of patients who have a lot of cardiovascular events, ticagrelor did 0 benefit over clopidogrel when clopidogrel works. Here's the outcome. Same. MI, same. Bleeding, same. Clopidogrel is no safer or no necessarily better or worse. Same efficacy compared to these when you make sure that it works. So there are some guidelines, there are some studies that are now suggesting if we genotype our patients, we may get better outcomes. This was a 2,500 patient trial published in New England. STEMI, they randomized everyone to either getting ticagrelor or prasugrel. Most of this was just ticagrelor, or they genotyped the patients and then switched the patients to Plavix if they were a Plavix responder. And you can see there was a trend. It was a non-inferiority trial, and the genetic testing was non-inferior. But there was a less bleeding outcome. Now, this was driven not by major bleeding, but minor bleeding. And so there is less nuisance bleeding, less minor bleeding with Plavix compared to ticagrelor or prasugrel. And that's what we saw in this trial. Now, there's other ways that impact the response of Plavix. It's not just the genetics, it's also how it's absorbed. There's other drug distribution, other genetic environmental factors. So some people say, let's not test the genetics because that's sort of upstream from the platelet, but let's actually test how the platelets are being inhibited. And that's what Verify Now does. You measure the platelet-induced aggregation, and it's expressed as a P2Y12 reaction unit, a PRU. So that's how we measure these. Now, there are data that have randomized patients with ACS. This is a study that looked at 2,600 patients randomized to platelet function testing, or they just give everybody prasugrel. So compared to universal prasugrel for all, the de-escalation strategy, the strategy of giving Plavix if it works based on platelet function testing, actually led to less events. It was not statistically significant, and again, it was driven by nuisance bleeding. It wasn't like saving stent thrombosis or major bleeding complications, but it was having less nuisance bleeding, which is a thing that patients care about. I mean, patients are going to come to your office and tell you that they hate all the nuisance bleeding and nose bleeding and the bruising and all that kind of stuff. And here's why I think this is the case. There's probably a therapeutic window for antiplatelet effect. I don't really know what it is, but just think of like the INR, right? If we did Coumadin, we want to hit 2 to 3, and we know that if it's above 3, it's bad, and if it's below 2, it's bad. But there's this sweet spot that sort of balances bleeding and efficacy. And that's what we see with platelet function testing. So this is using Verify. If you see in this reference group somewhere between a PRU of 100 to 150 up to 200 maybe, that's sort of the sweet spot. And then obviously as you become less inhibited, you get more stent thrombosis and MIs. But if you become more inhibited, you get more bleeding. And most of prasugrel and ticagrelor are going to put you in this quartile 1. And so what I think happens is when we compare prasugrel for all or ticagrelor for all, what you're doing is you're comparing one group that is in this quartile where there's a little bit more bleeding, and you compare it, you get rid of these patients because they're eliminated with genetic testing and Verify Now, and you have an average of these 3 groups. So you end up with more patients. If you do genetic testing or platelet function testing, clopidogrel, you end up with more patients in the sweet spot and you get less nuisance bleeding. So I love clopidogrel with one caveat. It has to know if it works. You don't know if it works, you can't be sure that you're in a good spot. So the non-SDACS guidance, they give it a week indication to think about it. So prasugrel is preferred over ticagrelor. Clopidogrel, guided by genetic or platelet function test, produces the same similar outcomes with minor bleeding. And I think you should not be writing for ticagrelor. So if you are, ask your attendings why. Here's a question that's going to come up, and there's no answer to it, but I want you to at least see this. Should you do this in elective PCI, right? Patient comes in, it's an elective procedure, the patient's got stable syndrome, they have an outpatient cath, you throw in a stent, and you put the patient on Plavix. We know that in the first 30 days, stent thrombosis is the most vulnerable time, but we also know that elective procedures have very, very low stent thrombosis rates. So here's the problem, and this is on clopidogrel. It's hard to move this needle, right? You want to reduce the incidence of stent thrombosis at 30 days in something that's 0.2 to 0.4%. You're going to have a ginormous study to look at that. And guess what? No one's going to fund it, so we're never going to answer this question. So you're never going to get the answer that you want. So don't ever think in medicine, ever know the answer to this question, because no one will do the study that is going to be required. To move this needle, it's going to take a huge, huge, huge study. So you either look at it and say, well, if it's not that important, then let's just give everybody Plavix because they seem to do okay. But if it were you and you wanted to move 0.2 to 0.1, that would be your question for you. There are two studies that have tackled stable angina. One of it's just recently published and presented called Taylor PCI. And only 16% of the population had stable syndrome. So they had 5,000 patients in the trial, only 16% were stable. So a very small group. So it's a very small subgroup of this. Now, genetic testing and switching clopidogrel was beneficial, especially within the first 30 days. When you went down to the subgroup here, of stable CAD, again, it was a small group, but those that got genotyped and swapped to prasugrel or ticagrelor did have less events compared to conventional. But this was only 275 patients. So is this random noise? Is this a signal that we should be doing this? Maybe. There was one other study, it's called Trigger PCI. It only randomized 200 patients and then stopped due to futility because they realized that they couldn't move the needle and it wasn't worth spending the money. What they found was those that got switched from Plavix based on platelet function testing did slightly better if they got moved to prasugrel. 200 patients. Is this random noise? Maybe. Does this make sense? And is this a signal that maybe testing is good? This is an unanswered question. We don't have an answer. It will never be answered. You're going to have to decide how you interpret that. Okay. What's the optimal duration of DAP? So here's what we want to spend some time with today, because this has really changed. And if you're not doing this, listen up, because I think the majority of patients are doing DAPs wrong. And when I'm not majority of patients, not majority of doctors. And that's because the guidelines have not caught up yet. We said that when you look at thrombosis that occurs in the year after a stent goes in, it's not equally distributed. Most of it is in the first 30 days. There may be a little blip in the first 90 days, and then it's pretty random and low level after that. Again, we said STEMI ACS, much higher risk of stent thrombosis the first 30 days compared to elective, right? It's hard to move this needle. So are there guidelines? Yes, they're from 2016. And problem, I want you to, and this is a problem in all of cardiology, the guidelines stink. And that is because they don't get updated quick enough. We move faster than the guidelines move. I'm going to show you DAP guidelines from 16. I'm discussing non-guidelines from 2014 and STEMI guidelines from 2013. The world has moved on from this. So the ACC is doing a really, really lousy job at keeping up with the guidelines, okay? So do not use the ACC guidelines. Now, I want you to know them because people are going to ask you them and they're going to test you on it. But good care is going to be in front of the guidelines, not behind the guidelines. So the guidelines say if you have non-STACS, you give a year of DAPT. The reason they give you that is they're going to cite a trial that's 20 years old. It was conducted probably 30 years old. And they're going to say the CURE trial, 12,000 patients with ACS. If you got Plavix and aspirin, you had a reduction in events compared to just aspirin. But only 20% of this group had PCI, and there was no drug-eluting stents. There was not contemporary medical therapy. This is not the patients that we treated. This is a population that we don't treat anymore. Now, there are some studies that have come out that have looked at shorter DAPT durations, but they kept patients on aspirin as sort of aspirin was the base of everybody got, and then you added Clopidogrel or took it off, and that was sort of the randomization of, of Plavix on, Plavix off. What you found is Plavix on, off, you weren't saving lives by giving a year of DAPT. So if you gave every one of your patients a year of DAPT for a decade, guess how many patients' lives you saved? 0. You didn't save anyone's life compared to a shorter strategy. The reason is that you just trade ends. You did prevent, if you gave everybody a year of DAPT, you probably reduced some myocardial infarctions, but you created some bleeding complications not occurred, and these balanced each other out, and in total, you do no benefit for your population. And that's what we've done. So for 2 decades, we've had a year of DAPT that has been our recommended strategy that has not saved lives. Now, there are some so when you look at this, you can say, well, what if I could just get rid of these bleeders? Then maybe I could prevent the myocardial infarctions if I could just get rid of the bleeders. So that makes sense, and that's a strategy that some have tried to adopt. And if you want to try to adopt that there are calculators out there. The best calculator, if you've just done the CAF, you're writing the CAF report, you're recommending the DAPT strategy for the PCI you've just done. If you write down the precise DAPT score and you download this calculator, and it's a very simple score, it only has 4 or 5 variables, it will tell you if you're high or not. And if you are high by precise DAPT, what you find out is that when you look at net benefit versus net harm, we create net harm patients when we give them DAPT that's longer than 3 or 6 months. So we should really give short courses, no matter what, if they have precise DAPT scores that are high. Now, does that mean if their precise DAPT scores are not high that they're benefiting? Well, maybe not, but at least we're not harmful as doctors, because it's one thing not to benefit, but it's another thing to just be harmful. We've just been harmful in this population, so let's stop harming those patients. So if you're going to write a DAPT, if you're going to write for 1 year of DAPT, you should have one caveat. I want everyone to do this. If you write 1 year, you should say because the precise DAPT score is not high. If you haven't calculated the precise DAPT score and you've recommended a year of DAPT, you are not doing great treatment. You're not doing the right thing. And the European guidelines recommend using precise DAPT score or you could use the ARC. I don't like this one quite as much, but you can use it, that's fine. So if they have high bleeding risk, just do 3 months, okay? Now, for stable ischemic heart disease, the guidelines actually 4 years ago moved to giving 6 months of DAPT. I never see doctors write for this. Although the guidelines actually said that it's a 6-month duration if you have stable ischemic heart disease. And that's because even 4 or 5 years ago, we realized that you weren't benefiting patients in terms of stent thrombosis, and you were causing more bleeding by giving stable ischemic heart disease longer durations of dual antiplatelet therapy. So for the last 5 years, we should have been giving everybody with stable ischemic heart disease only 6 months on average. I've never seen somebody write this. So I've never seen somebody follow the guidelines. I've never seen somebody follow this evidence. Almost always do I see people write 1 year. They put in a stent, they write the CAF report, and they give 1 year. Now, you can say, well, I thought we really needed to keep giving people Plavix over and over and over again, and extended DAP was really the way to go. The guidelines give it a 2B recommendation for extended DAP. I would rewrite it actually and say I would make it a class 3 for extended DAP, except for selected patients. And let me show you what I mean by this. So the DAP trial is a large trial, very important, almost 10,000 patients. If you were doing well at a year, you came back to the year mark, and then basically they randomized to either filling the clopidogrel, staying on DAP, or stopping the clopidogrel and coming off and just staying on aspirin. What they found in the DAP trial was that there was a benefit if you stayed on aspirin and Plavix compared to just aspirin. Now, it was a modest benefit, your number needed to treat, but it was a positive trial. And so people said, oh, we got to keep doing DAP. That's a good thing because we like positives, and p-values are really important to treat. And so, this p-value was good, so we treat p-values, and we got to keep doing DAP. The problem is that this trial took a long time. It was a great trial, big trial, but we changed the way we practiced during the middle of the trial. So half of the trial population ended up using stents that nobody has access to anymore. First generation DES, you can't even use them. So only half the trial actually used Xience stents used today. So when you go back and look at the Xience stents that we put in and look at the DAP trial, there was no benefit. So the population that we take care of today in 2020 did not benefit from extended DAP based on that type of stent. And there was more bleeding in the population. And if you take the majority of randomized trials and say, okay, I tend to give everybody long extended, if the people are doing well, I leave them on. And if I leave them on DAP, that's the leave on DAP strategy, and I randomize that to a shorter DAP strategy of less than a year. What we find is that in total, those that get left on DAP are dying more. There is more mortality in patients with extended DAP compared to short DAP. Short DAP is actually improving the mortality. Now, people say, well, maybe what we should do is use the DAP score and use a DAP calculator. So there is a DAP calculator that was based on this DAP trial, and it has these variables, and you can put it in your score. And so you can say, okay, well, when my patient comes back and sees me at their mark, I'll put these little things into the DAP calculator. And if their DAP score tells me to give Plavix, then I'll give the Plavix. And that makes sense. So at least what you're doing is you're taking away the half of the population that's harmed. Half the population will have a low DAP score. And when you look at outcomes in contemporary patients, the contemporary patients that we take care of with, Xience stents, if you have a low DAP score and you get Plavix and aspirin instead of just aspirin, you aren't saving lives. You aren't saving myocardial infarctions. Plavix is causing a lot of bleeding, and we're killing more people. So if you give, which is often done, extended DAPs to the low DAP score population, we're causing net mortality. We're shortening the lives of our patients in that group. Now, you would say, well, the opposite must be true, though. If the DAP score is high, then maybe we're saving the lives of patients, and maybe we are. It does seem that if you continue DAP and the DAP score is elevated, that we are reducing myocardial infarction, and we're not really having a huge increase in bleeding. So there's benefit without as much risk. That should improve the lives of our population. Unfortunately, in this trial, it didn't improve death. Now, why is that? Maybe it's just random play of chance, and if we replayed this study again and larger, we'd find that there would be a mortality advantage. Maybe. Or maybe just extended DAP is just not the way to go. So what I want you to take away is that extended beyond a year has never been shown to save lives. So that's the first takeaway. There's no data that we're saving lives. And if anything, the data is the opposite, that we're shortening the lives of our population by giving extended DAP. So the real question is shorter DAP preferred? And there's now some large trials that are moving in that direction. The Twilight trial, very important, recently published and presented, took 9,000 patients undergoing PCI, randomized them to 3 months, 12 months. Here's where the change occurred, and I'm going to show you 5 trials here that are real important. Instead of making aspirin the backbone of the antiplatelet strategy, The switch here is Plavix, or the P2Y12 inhibitor, becomes the backbone. And the variable drug that gets taken on or off is aspirin. So in Twilight, they got aspirin and ticagrelor for 3 months, and then they either stayed on it or they dropped the aspirin. So this is dropping aspirin strategies. In Twilight, when they dropped aspirin at 3 months, they got better outcomes. They had much less bleeding compared to staying on the aspirin at 3 months without any increase in death MI. And this was stable ischemic heart disease and non-STACS. There was no STEMI in Twilight. There were a lot of complex PCIs. This all up. You say, well, what about I just put in 3 stents? What about I just put in 60 millimeter stents? What about I just did bifurcation PCI? What I just did a major CTO? These things are so complicated. There's so much metal. I've got it. I can't not give a year of aspirin to these people. So that's what they did in Twilight. They said, well, does aspirin help those? And the answer was no. You do a really complicated PCI. Does aspirin help after 3 months? No. Smart Choice did the same thing. 3,000 patients randomized again at the 3-month mark. They stopped the aspirin. About 3 of the population were on Plavix. About a quarter was prasugrel ticagrelor. A fair bit of this was ACS. There was STEMI. Same outcomes. You stop the aspirin at 90 days, and there was less bleeding, no worse outcomes. Again, benefit without so no, you got rid of the bleeding without a price to pay. STOP-DAP2 really is interesting. They got really aggressive. 3,000 patients randomized at 1 month, so they only did 1 month of aspirin versus 12 months of DAPT. Again, about 60% Clopidogrel, 40% prasugrel, about 40% of the population was ACS. There was some STEMI. Again, just getting a 1 month of aspirin reduced the bleeding complications. Only a month, you had no price to be paid by getting rid of the aspirin. As long as you stayed on a maintenance of P2Y12, Clopidogrel, that was your background. HICO trial did the exact same thing in only ACS population. So this was a third STEMI, a third non-STEMI, a third unstable angina, whatever that is. 3,000 patients with ACS undergoing PCI at the 3-month mark. Again, stopped the aspirin and compared it to 12 months. And again, if a third of the population we said was STEMI, if you got rid of the aspirin, you got less bleeding. And so here is here's a meta-analysis of 32,000 patients, 5 randomized trials. It also showed global leaders in there doing either 1 to 3 months of aspirin, not 1 to 3 months of DAPT, 1 to 3 months of aspirin. So the background is P2Y12 inhibition. And what you see is you get a marked reduction in bleeding with absolutely no price to be paid. And when you go down and look at some of the individual outcomes, there's no price to be paid within thrombosis. And interestingly, when you look at death, all-cause death, it's not statistically significant, but it's trending strongly towards about a 15% relative reduction in death with these short courses. And it fits with that other DAP data. The data is suggesting that when we keep on aspirin and Plavix and we keep patients on it for long periods of time, we are shortening the lives. Now, it's not a dramatic shortening, but there is no benefit. There's no mortality signal that we're helping people with more DAP. The opposite's true. We should be shortening these courses down to 3 months. And again, if you look at just the ACS population of this randomized trial, there's no price to be paid by getting rid of aspirin at 3 months, and there is certainly less bleeding. I want to show you one other trial. This is not ACS population, but the MATCH trial. You might not have even heard of this, but this was a trial of DAPT versus Clopidogrel monotherapy. So this is the variable is aspirin. Everybody in this trial had a stroke, and then everybody got Clopidogrel, and then half group got aspirin. So the question is, see, the data before was was randomizing on a background of aspirin, whether clopidogrel helped or didn't help. Key background is clopidogrel, and does aspirin help or not? And on a background of clopidogrel for everyone, the addition of aspirin did not improve outcomes, but it increases bleeding. So what you're seeing is that you're getting sort of maximal platelet inhibition on a baseline of P2Y12 inhibition. And aspirin only adds bleeding. It's not helping. And just one other thing, I just put this in real quickly because it hasn't been published or presented, but it was one other trial that came out of, I think, the European. It sort of suggested that a year of DAPT, full dose prasugrel or ticagrelor is, again, not the way to go. They did a different strategy. I'm not recommending this, but it was interesting. They did aspirin and prasugrel 5 compared to aspirin and prasugrel 10, and there was better bleeding and no price to be paid. I show this now because I showed you 5 randomized trials, then I showed you the match trial, and then this is a 7th trial. 7 trials are coming out. The loser in all 7 trials is 1 year of DAPT with aspirin and ticagrelor or prasugrel at full dose, full strength. So the thing we recommend, the guideline-based care, is the loser in 7 of 7 trials. So I think the Europeans are on the right track, that stopping aspirin after 3 to 6 months should be considered in many patients. And here's the question I think that now is being asked, and this is a really interesting question. If you had a PCI and time has gone by and you're 6, 12 months, 24 months on your procedure, and you wanted to take one antiplatelet agent, just one, what would you take? Your options are aspirin, Plavix, prasugrel, or ticagrelor. I think we all wouldn't do ticagrelor. It's expensive. It's twice a day. I can't remember to take medicine once a day. It's hard. That's hard enough. So I think ticagrelor is out. But if you had prasugrel, clopidogrel, or aspirin, what would you take? Now, prasugrel, as we said, has gotten pretty cheap, but it's not as cheap as Plavix. There are 2 studies that have looked at what's the best monotherapy. One of them was the global leaders, and it was sort of a sub-randomization, but they took patients at 1 year to 2 years, and all the patient was either half the patient was on aspirin alone, or the other group was on ticagrelor alone. What you found is that those that were on ticagrelor compared to aspirin, this is just all patients to get PCI, there was less events if you were on ticagrelor. But it wasn't a dramatic increase. You would think that there'd be a huge increase in bleeding if everyone was on ticagrelor compared to aspirin. And there was a little bit more bleeding, but it wasn't huge, and it wasn't even statistically significant. It was a little bit, but the benefit seemed to be less than the risk. And then there was another trial, very well done and published long ago, the CAPRIE trial. They took 20,000 patients, randomized aspirin to clopidogrel. And there was a benefit. Clopidogrel was better than aspirin. Now, the absolute benefits were pretty marginal. The numbers needed to treat were pretty high because you're talking about single antiplatelet therapy in a, basically a primary prevention or secondary prevention population. Those event rates are low, so the numbers needed to treat are really high. But clopidogrel came out ahead compared to aspirin. And this is the interesting thing, there was no increased bleeding compared to clopidogrel. And here's what I think. This is just me, my guess. So is clopidogrel and ticagrelor more potent than aspirin? I think the answer is yes. Like if you said inhibition of platelets with a P2Y12, inhibition of platelets with an aspirin, yes, I think the inhibition of platelets is weaker with aspirin. But bleeding is not only related to inhibition of platelets. There's a second reason that patients bleed with aspirin, and that's because it's an NSAID. It's an irritant. It irritates the lining of your stomach. And a lot of this bleeding that we see in patients is GI bleeding. And there's clear data if you look in the literature, that you get more GI bleeding with aspirin than clopidogrel. So here's what I think happens is that you're able to tolerate, for the same bleeding risk, a more potent antiplatelet if you give somebody clopidogrel or ticagrelor. So that's my takeaway, is that if you were going to be on one agent, I would make it a P2Y12. Now, if you said, so back to this question about platelet function testing and genetic testing of clopidogrel. If you were going to take one agent, I would take Plavix with one caveat, because I think Plavix is cheap, it's generic. It probably is a little bit more in the sweet spot of that therapeutic window compared to prasugrel or ticagrelor. It's probably more potent than aspirin, and it's probably the very best drug there is for patients if you were going to take one agent, with one caveat. Wouldn't you want to know that you're a responder? So I don't have data to say that you need to test everybody and leave everybody on a background. We don't have that data. I doubt we'll ever get that study. We'll see if somebody does it. We need a huge study of primary or secondary prevention. So we'll never probably get the answer. But to me, clopidogrel seems like the drug of choice, and that so I'll tell you what I'm doing. I'm getting rid of aspirin. I'm not using aspirin in my patients anymore. I'm Plavix as my drug. That's the antiplatelet for patients with CAD, is Plavix, with the caveat that we test them and know that it works. So here's what I'm thinking. Most patients with acute coronary syndrome, I do 3 months of aspirin and Plavix if you're a responder, and then Plavix for life. And if you're a non-responder, aspirin and prasugrel for at least 3 months. Then the question is what to do after that point. That's the trick. What do you do then? Well, it'd be reasonable just to stay on prasugrel for life. How much data do we have for that? 0. Reasonable, 0 data to guide us. It's also reasonable to do aspirin and Plavix, then guided by the precise DAPT and DAPT scores. We do have data for that. Is that the best thing to do? It seems weird to like test for Plavix, tell you that they're not going to work, and then give you Plavix back. The way I think of it, it's not that Plavix doesn't work, it just doesn't work as well. So if Plavix doesn't work as well, it's reasonable to add the aspirin back to it. But if you're a very high bleeding risk person and your precise DAPT score or DAPT score says you're too high risk, then just get rid of the Plavix and keep them on aspirin. Does that make sense? So I would use aspirin monotherapy guided by precise DAPT and DAPT scores if you're a non-responder. I do think prasugrel is reasonable with the caveat that there's 0 data for that. So that is DAPT. So bottom line, I think 3 months of DAPT is the way to go for most patients. I think we should be genetically testing, and I think clopidogrel is a fantastic. Now the question is, I told you that DAPT stinks, right? I showed you all this literature that DAPT stinks. So the question is, instead of DAPT, should we be doing aspirin and low-dose rivaroxaban? And so when you look at thrombosis and you look at it, if you pull out a thrombus from an ACS patient, you see these lines of Zahn, which are these layers of platelets and fibrin and red blood cells. So intuitively, when you look at this, you're saying, instead of just hitting the platelets once and then hitting them again, doubling down on the platelets, I see 2 lines. Treat the 2 lines differently. So I'll hit the platelet, the pink with the antiplatelet, and I'll hit the red with an anticoagulant. Makes sense. Complete sense. So Compass did that. Very large trial, very well done. CAD, they excluded DAPT patients. They looked, it was a 3-way randomization. I'm just going to focus on the two-way randomization of aspirin versus aspirin and anticoagulation. There was a benefit. Number needed to treat 77. Now, 3 things about this trial. Fantastic trial, large, well done. 2, it was stopped early due to a benefit. So that is pretty impressive to have that. But what was really interesting and what caught my attention was what drove the benefits, and it was mortality. Again, I showed you that DAPT was not saving lives. So here's a dual strategy, and lives are being saved. That should catch your attention. And it was reducing stroke. Interestingly, though, it didn't reduce heart attacks. So the question is, how are patients living long? I mean, what was the mechanism? Are we just reducing fatal MIs, fatal strokes? Are we preventing pulmonary embolism? I don't know, but it was interesting, very interesting. So it caught my attention. I really wanted to believe this data, because every dual strategy, though, has a price to be paid, and you get more bleeding. And certainly when you do that with rivaroxaban, you get more bleeding. So there was a harm. So the question is there a mortality benefit, right? If there's a mortality benefit that overwhelms this harm, then it's a good thing to do. But if it's not, then it's just no. The question is this mortality benefit real? So Voyager came out with a similar strategy in the PAD population, and they looked at another large randomized trial of patients with peripheral disease, aspirin with or without the rivaroxaban. And when they looked at their mortality, there was no signal towards a mortality benefit with rivaroxaban. So suggesting maybe that was just noise that we saw in that first trial. And then there's another trial that looked at two dual strategies. So everyone got two drugs. One trial was randomized to aspirin and Plavix. The other group got Plavix and rivaroxaban. Aspirin and yes. So hang on, let me say that again. I confused myself. Everyone had P2Y12 inhibitor, and then the randomization was aspirin versus rivaroxaban. So DAPT versus rivaroxaban and Plavix. And what they found was the strategy of anticoagulation did not improve outcomes, and it wasn't any safer in terms of bleeding, and there was no mortality. But so I really was intrigued by COMPASS. I wanted it to be true. I still sort of in my heart kind of think it's interesting and intriguing, but it's expensive. It's twice a day. I mean, it's just as expensive as Xarelto for AFib. So, what do I think? Should we do it? I don't know. I don't think so. I'm not doing it until I'm not convinced that this mortality signal is real now. I really wanted it to be true, but I really don't. Okay, there's 10 more minutes. I want to go through this. I think you guys know this, but what do you do if the patient needs anticoagulation and you just put in a stent? Okay, I think we know this now. There's now a lot of data, meta-analysis, a lot of randomized trials that if you give 3 drugs, aspirin, Plavix, and the anticoagulants versus 2 drugs, get rid of the aspirin. Remember, the moral of all this, the theme to all this is get rid of aspirin. Aspirin, take it out and just leave them on P2Y12 and anticoagulation. No aspirin strategies, clearly reduce bleeding, and there's no price to be paid in terms of stroke or MI. So we're pretty comfortable now getting rid of aspirin when there's anticoagulation needs and a stent goes in. We're also, I think, pretty comfortable with what's better. There was a question for a while: do we use our new agents, the novel agents, the NOACs, the DOACs, whatever we want to call them, or do we use Coumadin? And I think we now, just like all the other data that's coming out there, that Coumadin seems to be the loser in every trial. Again, it's the loser in this strategy too, that if you use the NOACs like apixaban, probably Xarelto, that you're going to get less bleeding complications compared to Coumadin. So like all places, I think Coumadin's on the out. The NOACs are the standards. Here's the, I think, the new thing that is important to know. Real question is what do you do for the first 30 days? So in all the trials individually, they didn't see a stent thrombosis risk by getting rid of the aspirin. But we know that getting rid of aspirin is part of the antiplatelet strategy to reduce stent thrombosis. So then when we start to look at the totality of data and the risk of stent thrombosis, what we were seeing is that you were actually having higher stent thrombosis when you got rid of aspirin. And again, when you look at where this stent thrombosis was occurring in the Augustus trial, they looked at the timing. And remember, we told you that the majority of all stent thrombosis is in the first 30 days. And 80% of all the stent thrombosis that occurred without aspirin occurred in the first 30 days. So it's this first 30 days that are different than all the other days to come. So, you know, this first 30 days period. And so the question is for 30 days, should you use triple therapy? Because there is an increase in stent thrombosis if you don't use triple therapy for 30 days. Because remember, we said these first 30 days is the vulnerable time for stent thrombosis. So what do we do for most? I think triple therapy for 4 weeks is the preferred strategy for patients who are not high risk, especially if you do complex PCI or ACS. Then you drop the aspirin, the dual therapy, P2Y12 inhibitor and anticoagulation. Our DOACs are the preferred anticoagulation strategy. And this is a group, I think we forget this a lot, but we should probably be using routine PPIs in these patients because of bleeding risk. Then the question, here's the thing that I think that people don't do. And so here is something that may be new to you. All right, a year's gone by. Patient has AFib, and you're going to keep them on anticoagulation for life. They're a year from their stents. They come back to you, they're on that Plavix, right? You dropped the aspirin 11 months ago. They're on Plavix. They did a great year. They still have CAD, right? They got 40, 50% blockages in those other arteries, but they have AFib. What do? What we're finding is that if you keep them on an antiplatelet, you're making things worse. When you look at registry data, those that get aspirin and anticoagulation, because they have an indication for anticoagulation and they have CAD and they have an indication for antiplatelets. So they have an indication for both. And if you leave them on both, what happens? You get more bleeding and hospitalizations, but you don't reduce anything. You don't have a net benefit. So this led people to say, well, let's do a randomized trial. And they did this nice trial in circulation. They were really answer the question. So they said, let's at the 1 year mark after PCI, if they have AFib, let's just drop the antiplatelet, keep them on an anticoagulation, and then randomize them to people with anticoagulation and antiplatelet. And they had to stop after 700 patients and publish their results because they could not get cardiologists to send them their patients, because all the cardiologists already knew the answer to this, right? Like everybody knew, all cardiologists already knew, you can't not give antiplatelet. I'm not gonna not give aspirin. That's like how could a cardiologist not write for aspirin for a patient with CAD? So they couldn't get cardiologists to write, so they had to quit the trial. And it mainly because cardiologists would not get rid of antiplatelets. If you put in a stent, it seemed like sacrilege to not give that person aspirin. A cardiologist just couldn't do it. Finally, they got another group of cardiologists that could do it, and they published this in New England. And 2,000 patients, AFib, PCI, the 1 year mark, they randomized them to anticoagulation versus antiplatelet and anticoagulation, and there was less bleeding complications. It got rid of the aspirin, and that improved the primary endpoint because it was less bleeding. So there's not much benefit in the vast majority of patients. The reason I think this is because this population is mainly AFib. AFib is mostly older patients, mostly have more risk than benefit when you talk about potency of antiplatelet. So it is now in the Europeans a class 1 indication. That's really nice. The Europeans, they're always ahead of us. They say, get rid of the aspirin at 1 year. Just leave them on anticoagulation, okay? Now, I'm not saying that you have a 30-year-old patient or a 40-year-old patient with VTE. You can make a few rare exceptions, but I would say 90–95% of your patients should not be on an antiplatelet after a year. They should be on just anticoagulation. So I drop antiplatelets in most patients, and this is the European guidelines. That's what they're suggesting. So and I like this table because what they kind of said is that if you're high ischemic risk, triple therapy for a month makes sense, then double therapy, which we said. If you are high bleeding risk right out of the gate, so maybe you calculate a precise DAP score, and their precise DAP score is through the roof, and they just had a GI bleed last week. Well, even despite the increased risk of stent thrombosis, you may choose to send that patient out without aspirin from the get-go. And you may choose to truncate their antiplatelet and get rid of all antiplatelets at the 6-month mark. So I guess what I'm trying to say is that you can start in highly selected patients getting rid of antiplatelets at the, you can get rid of DAP from the get-go, and you can get rid of all antiplatelets up to 6 months if you want to, if they're high risk. The last question, I can do this in 1 minute. Should you use Cangrelor? The answer is no. Cangrelor is an IV agent, very short half-life, very quick on and off. Here's the bottom line, that when you look at platelet inhibition early on in patients with stent compared to GPIs, the Cangrelor is pretty weak. And if you look at it again, here's platelet inhibition again. This is our platelets with patients with high on-treatment platelet reactivity. You wipe out the platelets pretty quickly with GPIs, and you don't do very much with Cangrelor. Cangrelor has been studied, and it took a lot of studies. They're really complicated designs. I'm not going to go through. They're kind of weird how they did them. And the bottom line is that when you look, it had to pool a bunch of data to find like a small trend that was driven by, small troponin bumps, and the number needed to treat for a real event like a stent thrombosis was really almost non-existent. And they do increase bleeding by about 30 to 50 fold. So don't let anybody tell you that Cangrelor is a safe drug. It does cause bleeding, and it's very expensive. So I don't know of any reason to give anybody Cangrelor. So that's my all right, I think that's it. That's ACS, DAPS. There's 1 minute left. Any questions? All right, y'all have a great day.
The preceding program is copyrighted by Emory University.